I think we're live. Hello, everyone. My name is Beth Faiman, and I would like to welcome you to this Facebook event, which is Living Well with Multiple Myeloma during Myeloma Action Month. And again, my name is Beth Faiman, and I'm a founding member of the International Myeloma Nurse Leadership Board, founded in 2006. I am a nurse practitioner, and I work at the Cleveland Clinic in Cleveland, Ohio. So today I'd like to speak with you about sharing your multiple myeloma story with other people in your community, other people with myeloma, their families, friends, and healthcare professionals who care for them. And I hope that through sharing my story will inspire you to share your story with others. I'm just going to take a brief pause and make sure I can see everything. Great, this is all right, let's begin. So I've done these Facebook Lives before, but they're always a little bit different. After I share my story, hopefully I'd like to share a couple of things with you, which include some exciting updates to neuropathy management and some survivorship research stories, and of course some question and answer. So the question is, how did I begin caring with patients with myeloma? Well, I've been involved in the care of patients with multiple myeloma since about 1994. My experiences during high school caring for elderly patients in need really prompted me to want to go on a career path of helping others. Well, first I wanted to be a social worker, but then that didn't work out, so I went into nursing. So I really first observed the struggles that patients with myeloma underwent going through chemotherapy and stem cell transplant, and I thought, gosh, maybe I can be there for them and really help them through what they're going through. Unfortunately, think about almost 30 years ago, this is before we had anti-nausea medications, really good pain medicines, and the supportive care was not really good, and so that was something that I was really passionate about, was finding control of symptoms, whether it's a pain medicine or just, being a comforting ear to hear from. And patients got really pretty sick. I started working not just with multiple myeloma patients, but with leukemias and lymphomas. I also worked in the palliative care board, where I would help people through their worst symptoms. Most aggressive symptom management was what palliative care was back then and still is. And that was really special, especially when they were at the end of life. So fast forwarding until 1997, I'll never forget, I was in the cafeteria getting my lunch. I was working 12 hours that day, and I was fortunate to meet a doctor came up to me. His name was Dr. Muhammad Hussein, and he said, I've seen you on the nursing unit, and I'm so excited to share that we have had 135 new patients with myeloma in the last year, and I'm building a multiple myeloma program. He had just joined with Dr. Jury and Susie Novus at IMF conference, and he was so excited to talk about some of the research opportunities. And I liked caring for myeloma patients. I liked caring for patients in the hospital at the time, though, and it was a unique opportunity to go to the outpatient, but I said, I'm still young, I have a lot to learn, I'm going to just stay here for a while. I saw how sad patients were when they were admitted to the hospital and they didn't have access to family, or they had to share TVs back then, and so being a comforting ear to listen to and provide the things that they needed to get them through the day was really important. One of the interesting stories I had was I had a patient that was admitted for this infusional VAD, the vincristine, adriamycin, and dexamethasone, and that was something that they would get an infused Mediport in their chest. They'd have to have a surgical procedure, and I'll never forget, I sat down on this patient's bedside, and it was a young guy, and he just couldn't believe that he was diagnosed with myeloma. But I got to know him through that hospital stay, and through subsequent hospital stays. I attended to their discharge instructions. I made sure I answered all their questions, and then fortunately we formed this bond, and I took care of him for an additional 15 years when I moved to the outpatient. Boy, do I feel like I'm talking on and on. I'm just going to do a time check pause and see if there's anything I need to do on my Facebook screen. Thank you for bearing with me. I'm pretty technologically savvy, but some of this technology isn't as easy. I'll tell you, I really appreciate this technology. But anyhow, so what happened after 1997? And you're thinking she's going to talk forever, and I promise I won't. But based on my unique experiences in caring for patients with blood cancers, I'm like, you know what? I went back to this Dr. Hussein and I said, I'm really interested in making the move to the outpatient, and I'm going back to school and I'm going to pursue a master's degree. And he said, Beth, why are you wasting time getting a master's degree? You should just go to medical school. And I didn't think that was something that was in my best interest because I worried about school loans. I already had plenty of them. How was I going to pay the bills? Where was I going to end up in school? I had family responsibilities. So I decided, I'm going to get a master's as a nurse practitioner, and I am going to learn how to best care for patients. And I finished in 2002, and when I finished, there were no nurse practitioners at the time at the Cleveland Clinic. So I'm like, well, this is interesting. I really wanted to work in multiple myeloma at the Cleveland Clinic, and there was no job for me. I don't know what I was thinking. But I went down the street and I had some great experiences as an inpatient nurse practitioner running a chemotherapy service. And then about a year later, I got a call from that same Dr. Hussein who brought me back to the clinic. And since August of 2004, I've still been in the same position as an adult nurse practitioner. But I was running clinical trials. I was getting people on some of these studies. This was, again, way before we started using Revlimid or even Velcade. But my experience in clinical trials led to the desire to learn more. I said, I might be a nurse practitioner, but I want to learn laboratory research. I want to understand the details of patients' bone marrow microenvironment. I want to understand the science behind protocol development. I want to interpret all these studies. And I think in doing that would help me explain them better to patients and conduct my own clinical research. So I obtained a PhD from Case Western Reserve in 2014. And since then, I've been continually involved in research. So today, after all these years in managing myeloma, and fortunately, through the good fortune of meeting the International Myeloma Foundation and being one of their founding members of the Nurse Leadership Board, I can't tell you all the wonderful people I've met, all the amazing experiences, and I still remain to this day passionate about educating doctors and nurses and other providers on the diagnosis and management of multiple myeloma. 25 years ago, I could have never imagined these advances. I remember hearing about CAR T-cell therapy in the early 2000s, and I thought it was like science fiction. You're taking the cells out, you're engineering them and giving them back to patients. Is that really going to work? And I was skeptical, but now we have 2 excellent CAR T-cell therapies approved. We have bispecific antibodies approved, and I am so pleased to share that I still follow many of my patients from the 1990s and early 2000s, and it's really been nice to build these relationships, seeing grandchildren born and people graduate high school, and getting those people who might not be fortunate to have that long lifespan, really being able to build relationships and support them while we can. So there you have it. That's my story. And don't forget to go to Myeloma ACTION Month or mam.myeloma.org to tell yours. But we're not done yet. As promised, I wanted to share with you 2 really exciting, I think, updates in peripheral neuropathy and survivorship. I might take a pause in just a minute, but I think I'll just go through these 2 points and then we'll have plenty of time to chat before our time is up at the end of the half hour. So first off, peripheral neuropathy. This is something that in the early 2000s when we started using thalidomide in high doses and then high doses of Velcade twice weekly IV, patients were suffering with these symptoms. So not only the myeloma can cause neuropathy symptoms, that numbness and tingling in the fingers or feet, it's as a result of the damage to the peripheral nerve. So we were really pushing them because their myeloma was responding. For the first time, we saw people go to 0 on their myeloma numbers. We used to call it plateau when they were in stable disease. That was like our best response. Now we're looking for VGPR, MRD status, and very exciting stuff. But it remains that neuropathy can be a very devastating, even mild neuropathy can be a very devastating side effect of the diagnosis or the treatment. This is caused by injury, inflammation, or degeneration of the peripheral nerve fibers. It can affect your quality of life, compromise your optimal treatment. So if you have bad neuropathy, some of the clinical trials you won't be able to participate in. Fortunately, that's changing. We're not getting to the severity of neuropathy as we once did, but myeloma-associated neuropathy has actually been reported since the late 1800s. Again, patients are living longer. I think there are so many different other things that can cause neuropathy, such as uncontrolled diabetes, vitamin deficiencies, particularly vitamin B12 deficiency, B6 toxicity. It's really a big deal. So how does this happen, this neuropathy? Again, it's from the disease, it's from treatment, it's from other conditions. So if you have a symptom, speak up. Make sure your provider knows about neuropathy. It could be very easy as checking a vitamin B12 level, or a vitamin B6 level might be toxic. There are 3 types of peripheral nerves: the motor, the sensory, and the autonomic nerves. Some people have neuropathies that affect all 3 types of nerves. Nowadays, and what's most common is those that affect the sensory nerves. Now, along that way, one of the things I don't always talk about when I discuss neuropathy is dermatomes. Like, it's something that is just, it's something that we don't really go into that level of detail about, but I found it was really important when I was talking about this new therapy I heard about that we've been using at my institution. Dermatomes are like a roadmap when it comes to the health and function of your spine and your nerves. What happens is that we know the spinal nerve is critical for a dermatome because it carries all the nerve signals back and forth traveling between the skin organ and the brain. Dermatomes are areas of the skin that really connect a specific nerve root. So for example, you can have a lumbar spine dermatome, which is at the end of the spine. And I'll show you a little picture. I'll do a little picture of a dermatome map that I share with all my patients. But the nerves travel. So sometimes if you have narrowing of your spinal cord in the lower spine, not myeloma related necessarily, maybe from arthritis, then that can make you have different sensation and different motor problems. When you have it that affects from the peripheral neuropathy, though, that's an area that tells us where the change in sensation is. Again, we know about neuropathy for many, many years, but we don't really have great things to treat it. My PhD dissertation, one of that was using high doses of oral glutamine to ameliorate neuropathy in patients receiving bortezomib or Velcade. We frequently use things such as Neurontin or gabapentin. There's Lyrica or duloxetine, which is called Cymbalta. I often recommend something called alpha-lipoic acid, which has been studied in diabetic neuropathy because it's very similar characteristics, just that change in sensation. Some people feel like they're stepping on Legos. Other people feel like their socks are crumbled underneath them. So it's really very different when you have that that neuropathy in the skin and the distal nerves, how it's talking to your brain. So as I mentioned, I was really excited to hear about a new therapy because there hasn't been any updated research in quite some time in neuropathy management. And there's something called Scrambler therapy, which I think of like scrambling eggs, scrambling cymbals. It's a non-invasive way to modify pain in patients who are not well managed with their chronic pain for varying reasons. The exciting thing is that we had this researcher from Italy in 2003, Giuseppe Marineo. He describes, like, out of 11 patients, 9 of them had horrible pain and terminal cancer, and they actually stopped using their pain medicines because of this Scrambler technique. There have been different machines, but now the latest one has been FDA approved in 2020. It's called the ST5A, and it's a non-invasive electric analgesia device. And that has 5 different channels. It kind of looks like an EKG machine, and you connect the leads to the different areas that might be painful or causing discomfort, and it's along those dermatomes. And there are 5 artificial neurons, and what they do is they scramble your signals to the brain. It gives you nerve impulses of information that is recognized as non-pain. Some people say tingling, some people say it's like little electroshocks or tickling, but it kind of mimics like a massage. And it remodulates the signals of perceived pain from your feet to your brain. And the cool thing about this is that it might not be perfect for everyone, but you have to do it daily for about 10 days with 2-day breaks. So like Monday through Friday, take 2 days off. Monday through Friday. So there is a time commitment that's available with that. But it follows a dermatome. So like in my institution, the physicians that do this procedure are palliative and pain specialists. And again, it works to scramble the pain signals to the brain from the skin because it's a two-way street. And there have been a handful of patients so far, not that many, but many of them, several of them have said that they have benefited in somewhat. The one of them I talked to the other day said, well, I thought I wasn't getting better, and then I did over the weekend, and now I can tell I might benefit from it again. And so they just sit in a chair for 30 minutes to an hour and read a book, watch TV, whatever. How is it different from a TENS unit? TENS stands for transcutaneous electrical nerve stimulation therapy, and that for years has been shown to help neuropathy, back pain, and various disease states, but that's administered by the patient and given in different areas that might cause pain. The Scrambler, again, interrupts the pain signals, and it's like a one-time therapy. So you do the 10 doses, 5 to 10 doses, and then you're done. There are some studies in chemotherapy patients, but because this is a newer machine, newer technology to the United States, there haven't been as many studies. So that's one of the things I'm looking forward to doing is perhaps, wish me luck, fingers crossed, finding funding through grant, sponsorship to convene a study. And, I think we only need probably 20 patients with myeloma, and the problem is the cost, as with anything. And right now you have to be specially certified to administer this to patients. So hopefully this will cause long-lasting relief. And some studies that were done over in Europe, 1 or 2 treatments really helped. Some people just on that first treatment helps, and then it might be worth going on to. But that was just updated. Some of the studies on this were updated in the last 6 months. So it's something that I hear a lot about on the myeloma page, so I thought I'd bring it up again. So, all right, well, so time flies. I mean, I could talk for hours on different topics. I do want to talk about the importance of survivorship in myeloma. I think we've all informally went to our provider's office and they ask about health maintenance, when you're due for your colonoscopy, blood pressure checks, cholesterol check, prostate checks. And some of your cancer doctors might do that. Sometimes they tell you to go to a primary care provider and ask them to do that. But I think one of the most important things we can do as providers in oncology that are seeing you on a regular basis, I think it's important that, and I might get in trouble for saying this, but I think it's important that we take an active role as oncology professionals in helping you navigate the diet, exercise, lifestyle modifications that are necessary, and have a formal survivorship program, which I'm implementing at my institution, where anybody who's finished with stem cell transplant will have regular visits at 3 months, 6 months, and 12 months, where we look at quality of life, we look at health maintenance, we look at long-term side effects, and then we'll follow you on a regular basis, and it'll be individualized. Maybe somebody lives far away and doesn't want to come but every 6 months, or maybe they want to come every 3 months, so we'll work with that individual to tailor a program that's right for them based on their needs. And we can do this virtually or in person, because we know survivorship in myeloma starts at diagnosis. And we also know it's a well-known fact that transplant patients might have long-term needs with survivorship. This paper that was published on March 2nd by one of my favorite myeloma physicians, used to be a fellow with me. Now he's at Columbia. It's Dr. Raj Chakraborty and Dr. Navneet Majhale. He's at Sarah Cannon now. So we're so sad to have left them, but they have done a lot of research in myeloma patients and survivorship on coordination with stem cell transplant patients. They just reported in their paper that patients who receive 3 drug regimens go into remission and then have a stem cell transplant, from several studies, about 7 years remission, which is great news. And if you're 65 years at that time, you might have new, more health needs like diabetes, hypertension, and heart, and all that kind of stuff. So they looked at survivorship importance, health-related quality of life, distress, healthy behaviors, and all these kind of factors that we would need to think about and take into consideration when we're looking at the survivorship needs of this growing population, because there were, what, 9,000 transplants for myeloma were conducted up until like 2018 in the CIBMTR database, which is the Center for International Bone Marrow Transplant. But at the study, they looked at adherence to guidelines such as exercise, alcohol, sunscreen, and diet, and other preventative strategies, and the findings showed that, as suspected, there was a significant health burden with like uncertainty of health and medical demands and financial concerns, but fortunately 81% were able to adhere to exercise guidelines and actually remain active. There was this questionable distress around adhering to alcohol, which I don't know what to make of that. It might be a limitation of the study. The other limitations might be that it was like a retrospective. We looked at old data, and then we also couldn't see what happened except in this little time point. But the take-home message here is that patients with myeloma are living longer than ever, and they have distinct needs for survivorship. And I think that it was good first novel study that I'm going to use findings from as I do more survivorship care in myeloma. So I guess that's it. I hope you found this to be interesting and informative to share information about myeloma. And this has been fun, and I still am here to answer some questions for the next 6 minutes. But another plug, don't forget to check out Myeloma Action Month or mam.myeloma.org to share your story, and go to myeloma.org for any questions and answers. Myeloma cancer, that used to be the cancer helpline, but it's more of a, oh, Robin Toohey, I'm so sorry, I forgot what it's called. It's the 1-800-888-452-CURE. Oh, you're on the website, you'll be able to find it. Before I go to questions, I want to kindly thank you to all the sponsors supporting Myeloma Action Month. That's 2seventy Bio, AbbVie, Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen Pharmaceutical Companies of Johnson & Johnson, Karyopharm Therapeutics, Pfizer, Regeneron, Sanofi, and Takeda Oncology. And please forgive me if I forgot anybody. I think at that time I'm going to ask for any questions. And oh, look at all the stuff in here. Okay, so let's see. We have some wonderful, my wife is coming up on stem cell transplant, yay! Coming up on 2 years, I take Revlimid, thank God. 17p deletion and a bone marrow transplant, yay, good for you. We have some really, really good messages in here. Good messages of hope. Yeah, please take a look at your, go to the website, and some of these stories are so inspiring. Important factors for living well. That we talked about the minimal residual disease and mass spectrometry, which are always very important. Info line, thank you, fearless leader, Yalak. The myeloma info line, that's what it's called. All right, so we have really good things. And yeah, I think that's about it. Talk about MRD test after transplant. Sure, why not? So MRD stands for minimal residual disease, and minimal residual disease is part of, I mean, I think of it as part of the Black Swan Research Initiative, you know, one of the IMF sponsored research things. And so I hear Dr. Dury had explained it before. You thought you'd never see a black swan until one day there's a black swan, much like we never thought there would be a cure for myeloma until we saw it. And some people are functionally cured and still in remission 8 years after transplant, with or without maintenance. We call those people exceptional responders. Nowadays, there's research and technology that can look at 1 in a million plasma cells in your bone marrow. Through a technique called next generation sequencing, researchers can look underneath the microscope and kind of pick out how many bad clones are in that bone marrow. And in order to do that, they take the original bone marrow biopsy, send it off to Seattle. clonoSEQ Adaptive Biotechnologies is the one that does it for me. I know there are some other in-house tests, but they'll compare the bad clones in the bone marrow to diagnosis, so you need at least 5% bad cells in there, to the after transplant marrow. Studies have shown that patients that achieve minimal residual disease Some of them say it doesn't matter how you got there, just that you got there. That was the IFM 2009 study of the Data Farmer and the French myeloma group had one study that said just get to MRD status. Some people say, well, maybe you're more likely to get there if you use a stem cell transplant to get there. And if you achieve MRD negativity, some centers are continuing to watch your MRD negative status. Now, we use it in the context of clinical trials. I don't typically use it to make treatment decisions. Like if I've had somebody on maintenance for 7 years and they're doing extremely well, they have no side effects from whatever maintenance they're on, or maybe they're not on maintenance, then we have that discussion. Now I think it'll be more important. So it's nice to know, but not need to know. If you're willing to go through a bone marrow biopsy is how we find out. Now we're getting some mass spectrometry and other cool techniques that might prevent us from having to have a bone marrow biopsy recommended to check MRD negative status, but stay tuned for sure. So I hope you found that helpful. And oh, I saw my friend Steve from Boca. I'm going to be in the Boca patient family seminar coming up. Thank you for inviting me. I live in Cleveland, Ohio, so I look forward to that in a couple months. And they have such good information through the IMF. So I think we're at 7:29. Let me just try to see one more time. Thank you again for that info line link and all these cute emojis. I appreciate that. And feel free to, again, reach out to the info line if you have any other questions, concerns, or follow-up on this presentation. You inspire me every day on a daily basis, all the patients and the caregivers and all of you that are striving to learn as much as you can about others. And I said a couple of times, don't forget to go and share your story. I feel like it can be very therapeutic. Share your clinical pearls. Share those things that got you through the tough times, and those might be something that resonates with somebody you don't even know. And that's what's nice about social media, is we can connect on a different level. So I think that's about it. Again, thank you for your time, and I hope you have a wonderful day, and stay safe, everyone. Bye.